How many people in America have type 2? I know it's a big deal, but how big a deal?
Well, when you combine prediabetes, which is a precursor to full-blown diabetes, and diabetes, you combine those two, it's more than half of the adults in the country.
Half of America.
Half of adults in America are affected, and more children are becoming affected as well.
Wow. So if you're walking down the street, half the people you see have diabetes or prediabetes.
Right. And the really unfortunate thing is that of those people that have either prediabetes or diabetes, more than half of those people are undiagnosed. They don't know they have it.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's so great to see you two. Welcome.
Great to be
Hello.
here. Hi.
So on the show this week, we're talking about something super important to Americans, especially now, and that is diabetes. Dr. Cooper, there are so many reasons that we need to be concerned about diabetes, but let's start with just what the definition is, because I think it's a little bit confusing because there are different types of diabetes and they manifest in different ways. What is diabetes?
That's true. Diabetes is a problem with blood sugar regulation that's associated with high levels of glucose in the blood. And there are different types, and this often is confusing for people. They're very different. Type 1 is much less common than type 2. Type 1 is an autoimmune disease where the immune system attacks the pancreas, which is responsible for producing a hormone called insulin. And insulin is the main hormone that regulates our glucose levels. And so people with type 1 diabetes have a problem where their pancreas really cannot produce insulin, and therefore their glucose levels get very high and they require medication, insulin replacement medication. They have to take insulin.
And refresh us why insulin is important and what it does in the body.
Well, insulin is the main hormone in the body that helps drive glucose, which is also nicknamed blood sugar. But glucose is our main energy source that circulates through our body. And insulin helps drive that glucose into the tissue so that they can use it for energy. So like into your muscle cells so that they can use it for energy. There are certain parts of our body that don't really require as much insulin in order to access that glucose. These would be like our vital organs and our brain, our heart, our brain. I mean, they can still access glucose without adequate insulin, but the rest of our body has to have this insulin in order to really use that fuel that's circulating in order to do the work that they do. So without it, it's life-threatening.
So type 1, the body has killed off our ability to create insulin, which takes that blood sugar into muscles for use. So what is type 2 then?
Right. So type 1 is that, and it's a pancreatic disease, basically, where the pancreas is unable to produce the insulin. Type 2 is a little different. With type 2, the idea is that a lot of the dysfunction starts outside of the pancreas and starts to increase the demand for insulin because there are problems with the insulin function throughout the body due to outside forces. And so that creates a strain on the pancreas where it has to kind of keep up with this insulin production that keeps ramping up and ramping up and ramping up in order to drive that glucose into the cells for use. And over a period of time, The concept is that the pancreas we don't want to say the pancreas is tired, but I guess it gets tired of pumping out that much insulin, and it can lead to failure of the cells that produce the insulin to actually keep up with that demand. And the levels of insulin produced by the pancreas start to decline often. And that just creates a situation where the glucose just rises and rises and rises into these high ranges.
If you have high glucose, which means like a high, like a high A1C or a high sugar level or whatever they're calling it in your testing, why is that bad?
Well, there's two reasons. One, high glucose means that your cells aren't getting that glucose to use for energy. So, number one, you're actually not able to get the energy out of the glucose. If the level's building up in the blood, it means you're not utilizing it as an energy source. But it also can damage a lot of our organs when it's elevated. And so there's more and more knowledge about what are called cardiometabolic effects and renal effects. Renal is kidneys. Cardiometabolic would be vascular and heart effects of high glucose. And then I think most people know that it affects the nervous system. Also, high levels can cause what's called neuropathy, nerve damage. And some of that nerve damage can lead to problems with our organ function, like our stomach's ability to empty at a normal rate, our things like what are called paresthesias, like tingling and pain in our extremities, inability to feel properly with our toes hitting the ground, loss of sensation. And then, of course, vision can be affected, circulation, because there can be both what's called macrovascular and microvascular disease, which means disease of the large blood vessels as well as disease of the small blood vessels. So you can imagine this just can create terrible consequences throughout the body, which is why diabetes is associated with increased risk of blindness, kidney damage, amputations, heart attacks, strokes. So
Wow.
it's not good.
So when we're talking about type 2 diabetes and the impairment of the body's ability to make insulin, can type 2 diabetes turn into type 1?
That's such a good question. And, long ago, people would tell you, oh, no, they're totally separate. Now they're they're finding out more and more how little we really know about diabetes, even though from what I've read, diabetes was first kind of recognized thousands of years ago, supposedly. And it's been studied for many years with the onset of ability to measure things in the blood work and to do repeated studies and look at the autoimmune system and the genetics. So we're starting to find out there are variants of diabetes that don't fall neatly in those two buckets, type 1, type 2. And so a lot of the terminology has changed over the years. There used to be a type 3, there used to be a type 3C, type 1/2. So people are trying to understand it. Now, I think what we're looking at is there can be some overlap. So normally type 1 diabetes is going to be early onset in childhood. It's also called juvenile diabetes. So usually it's detected early in childhood. And whereas type 2 diabetes is something that develops over time and is found at later ages, either later in childhood or adulthood. And type 2 is way more common than type 1. But they're starting to see that there's a later onset of autoimmune disease that affects certain people where they have type 2, but then they develop those antibodies that can attack the pancreas similar to type 1. And so they can end up showing signs that they actually need to go on insulin earlier than most people that have type 2. And they have more life threatening complications than the main group of type 2 patients. So there is a little bit of overlap there. And there are other things that can cause diabetes outside of those two things. For example, pancreatic disease. People who have disease of the pancreas can develop diabetes due to the dysfunction of the pancreas.
And then I know, like, my mother had gestational diabetes when she was pregnant. What does that really mean?
that's a really important area that we should be looking at, gestational diabetes. In the world, there's kind of a high rate of gestational diabetes. The World Health Organization um, reports kind of high rates of it. And in our country, the rates are lower, but they're increasing. But one of the reasons why they're increasing is better screening. It's not necessarily that they're actually increasing, it's that we're still missing an awful lot of gestational diabetes diagnosis in our country. Um, and that has to do with our screening tests not being thorough enough typically. But gestational diabetes is a situation where the blood sugar elevates above a baseline, a normal baseline, but limited to pregnancy. So the person prior to pregnancy did not have diabetes, but during pregnancy, with a lot of the changes that are occurring in pregnancy, they can develop elevation of glucose that's beyond what's considered a healthy range. It's much more strict. The cutoffs are much more strict in gestational diabetes than actual diabetes. So, very mild elevations are labeled as gestational diabetes. And if those were outside of pregnancy, they would not be labeled as diabetes outside of pregnancy necessarily.
Do we know what causes gestational diabetes?
Well, normally, both type 2 diabetes and gestational diabetes are really linked to genetics for what we call our term diabesity. It's not really our term, but it's a term that connects both diabetes and obesity to a common underlying what's called pathophysiology, which means the mechanisms of disease that can relate to both of those conditions that can bring it on. But genetics plays a major role. And while people that have a high body weight are more prone to gestational diabetes can also occur at a completely normal body weight level. But it's in pregnancy, a lot of hormone changes take place and a lot of changes in glucose levels and insulin take place. And a lot of that is to benefit the baby, to help the baby make sure that the baby has enough glucose and fuel. And so sometimes during that process, the dysfunction can kind of turn on in a person who's prone genetically to diabetes. And the other thing that can increase your risk for gestational diabetes is if you've had it with one pregnancy, it's much more likely you'll have it with another pregnancy. And if, say, your mother had gestational diabetes, it's more likely that you might have gestational diabetes too when you become pregnant. It's not, necessarily guaranteed you will, but that's why we need better screening to see who is at risk actually and make sure that we're screening thoroughly enough.
Right. I don't know how my mother found out she had it, like if they just did a routine test, but she wasn't overweight when she got pregnant. She was really thin.
Mm.
But how do they do screenings now? Do you think it's like in the typical battery of tests?
It's funny, but the American College of OBGYN recommends screening around 28 weeks of pregnancy with what's called a glucola test. So it's what's called an oral glucose challenge. So you're given that sweet sugary drink and then your glucose is checked both before in a fasting state and then an hour after you drink that. And that's considered the kind of common screening. And then the glucose level is measured there and it's determined based on the fasting or the after drinking this glucose drink level, whether you fall into that range. But the concern is that the rest of the world uses a more detailed test. So our 1 hour screening, if you don't pass that, you go on to do a much longer glucose challenge test. But in our country, we always start with that 1 hour screen.
When I do my eating tests, I see them at the
Yeah,
at the lab.
right. But in the rest of the world just doesn't do the 1 hour. They do the long test more
Oh,
routinely. They skip that and they just do the longer test. So some of the thinking is that they're picking it up at a better rate than we are because we're not really jumping to that longer test, even in people who we think might be higher risk because of their genetics and family history. We're still relying on that shorter screening test, which can miss a lot of cases. And so
Interesting.
some of the estimates are pretty high that look at how many cases we think we're missing in the US. It could be up to 2/3 of the cases that are being missed.
That's interesting. Now, I had diabetes brought on by steroids that set me into almost a diabetic coma.
Yes.
So, like my levels were at like 8.9 or something, and my primary care physician was like, "You're almost in a diabetic coma. Get in a cab. Get back to the hospital and learn how
Whoa.
to shoot yourself up with insulin."
Right.
And then that set everything on a crazy track because all my other medicines, we had to like bring everything back down. But that is another thing that can bring on diabetes is other medications.
That's a very good point, especially if you have the genetics. And
Oh, which I did.
which you did. And so we do have a concern about children too that are exposed. Say you're a child and your mom had gestational diabetes. That is going to contribute to the offspring increased risk of higher body weight, more visceral fat, which is around the organs, insulin resistance, and prediabetes and future diabetes, all of those things. And then
Check, check,
yeah.
check.
And then if some of those kids develop some conditions such as asthma or maybe an inflammatory bowel disorder, anything like that, they may require steroids. And so then once they go on the steroids, it can actually activate, even at a young age, a course that really pulls them towards this, what we used to be thought of as an adult disease, type 2 diabetes. So steroids definitely are such a necessary medicine for certain conditions because it can be life savings. But we need to be monitoring really closely people that are at risk. And more, we're thinking we need to be maybe putting some other medicine in there to counteract those negative effects of steroids earlier. Same thing with antipsychotic medications. Certain antipsychotic medications also can be triggering as well.
So, this is a really interesting discussion, Dr. Cooper, about diabetes. And because diabetes involves insulin and how it reacts in our body and glucose levels, let's talk about metabolism in general and the fact that, I was pre diabetic when I came to you. There was a lot of metabolic dysfunction in my body. But what is the correlation between the disease of diabetes and our ability to regulate metabolism and weight and health?
They're really linked because if you think about it, especially type 2 diabetes. Now, type 1, I feel sorry for people who have type 1 diabetes because they get pretty frustrated that they're kind of put in the same bucket with everyone who has diabetes when it's much more uncommon to have the type 1 and it behaves totally differently. Well, people that have been on long-term insulin therapy for type 1 can develop similar metabolic imbalances that people with type 2 have. It's very different. So when we're talking about diabetes in this case right now, we're talking about type 2 and how that affects, how metabolism affects type 2 and how type 2 diabetes affects metabolism. So in prediabetes and type 2 diabetes, because of course with type 1, there really isn't a pre-diabetes phase. I mean, you find out you have type 1 when you end up in the hospital with what Andrea was describing as a diabetic ketoacidosis coma, something like that, or a risk of like completely uncontrolled glucose. So there's not really a precursor stage as much, although there is, but it's very subtle. But in type 2, the precursor stage is prediabetes. And during that, there's even a precursor to that, actually, which usually involves something called hyperinsulinism, which means insulin levels that are too high. And most people think that's always associated with what's called insulin resistance. But technically, it's not always associated with that. The high insulin levels that are circulating, insulin is a wonderful hormone. It's very important when it's in the normal range. But if it's too low or too high, it starts to cause problems metabolically. So if it's too low, the body thinks that you must be starving and not have enough nutrition. If it's too high, it starts to create resistance throughout the body so that it starts to affect our body's utilization of glucose that we were talking about. And that means Your muscle metabolism will slow down. It often means that your liver starts to dump out extra glucose for your body to use inappropriately. So all of this starts to affect body weight because then your body fat starts to take up that extra glucose and you start to gain weight. It also affects blood pressure because high insulin levels increase our muscle, smooth muscle that's lining our blood vessels. So it causes like what's called a hypertrophy of that muscle. And that makes your blood vessels tighten up because they're more muscular. And that leads to hypertension.
That is so interesting.
Yeah,
Wow.
it is, isn't it?
So
It's
that's
like
why they're all connected.
it's all connected. And that's kind of how the metabolic syndrome is a part of that. You know, those high insulin levels also trigger more the high triglyceride levels that you start to see. And the HDL cholesterol, which is the nickname, the good cholesterol, starts to decline. Testosterone levels are affected. I mean, and with what's called PCOS in women, polycystic ovarian syndrome, the high insulin can also trigger that type of dysfunction where women start to produce excess amounts of what are called androgens and not ovulate normally. So it all starts this like complex metabolic dysregulation cascade.
I know that there are drugs that can control a lot of diabetes, like for type 2, like metformin, which is a drug that I think you told me a long time ago that it was invented like 100 years ago or something. And but then we have our new drugs like Ozempic and Mounjaro and all these new drugs. How do they control the diabetes? Because that's what they were invented for.
That's such a great question. It's so interesting because they work differently. And up until fairly recently, if you think about it in a bigger time frame, we didn't have very many drugs. You know, there were really only a few drugs used in diabetes, and metformin was always one of them because it is one of the oldest ones. It was approved throughout the world in the 1960s, but in the US, 1995, it was approved. It took us longer. But there was metformin, and then there are certain medications that would help your body make more insulin. There's certain medications that would try to make your body more sensitive to insulin. But a lot of those medications come with more side effects like risk of low blood sugar reactions or possible risk of weight gain, which is not what people want to see.
Right.
Metformin has stayed the course, and it's been a very useful med. It mainly works on the fasting state. So when you're fasting and you're relying on your liver to release glucose, the metformin helps improve your liver's sensitivity to insulin so that it releases the glucose at a more even pace. And over time, what that does is it not only helps your glucose not have those high levels, but it helps your pancreas not have to like pump out extra insulin to match that glucose. So it's still a very useful medication, and it's kind of unique what it does. But the more we've learned about diabetes and about diabesity, or if we want to call it just metabolic disease, dysfunction related to this, the more we understand that there's both, you know, the blood sugar regulation issues and cardiac risk, blood pressure risk, kidney disease risk, all of those things. And so the newer medications are now starting to show that they actually improve more areas that diabetes is affecting. And so we're looking at diabetes differently now, trying to look at people with diabetes and who has that elevated cardiac risk, who has that elevated kidney risk, intervening earlier with key medications that not only get to the root of the diabetes, but also have shown great benefit at reversing the cardiometabolic or the kidney damage that's there. And so it's really getting to be a lot better, a lot more choices now. So when you talk about the GLP-1 medications or even the newer one, the GLP-GIP, which is the tirzepatide, which is Mounjaro, when you're talking about those medications, they're mimicking hormones that our body already produces that are in our gut. They're called incretins. And those hormones have been known for a long time to have powerful anti-diabetic and anti-obesity properties. And what they're learning is they also have powerful effects on reducing cardiovascular risk and improving kidney function and reducing, even now they're kind of looking at them in diseases such as Alzheimer's and other things. I mean, even with metformin, they found that it seems to be reducing the risk of atrial fibrillation, seems to reduce the risk of cancer in some cases. So these medicines have widespread effect mainly because they are working on your metabolism and improving that glucose and insulin balance, which has such a widespread impact on all your body function. So, but the way that the newer medications, these incretins, work is if your glucose is too high, it actually stimulates your pancreas to produce more insulin to match that glucose to pull it back down. And at first, they thought that it was taking those tired beta cells in the pancreas and kind of rejuvenating them. Then they realized it was actually helping develop brand new ones. So those cells that produce insulin in the pancreas are stimulated by those medications, but they never will lower your glucose beyond normal because it only has that effect if your glucose is high. So that's why they can be used also in obesity without diabetes, because they don't always pull your glucose down. Only if your glucose is high, it stimulates your pancreas to produce more insulin. And that insulin helps pull it down. At the same time, they actually help prevent another hormone that's in your pancreas, which is called glucagon. They help prevent that hormone from getting too high inappropriately. Because what glucagon does is it tells your liver to dump out all the glucose that's stored there to give you more energy. But again, if your glucose is already high, you don't want your glucagon to go up. You want it to go down. And if your glucose is high, you want your insulin to go up. So these meds are perfect because that's what they do. They're based on your glucose. They help regulate those two hormones to keep your blood sugar in balance. And so it's really fabulous. And there is another group of hormones, of medications, I don't know if you've heard of, called SGLT2 inhibitors. That's another group that first came out and people were kind of like very skeptical because what they do is they help your kidneys just dispose of more glucose. So, you know that people check their urine, and if you see glucose, that's a test for diabetes, if you're spilling glucose into your urine. But these medications are saying, well, if your glucose goes above a certain amount, your kidneys should dump out some extra. And so everyone was kind of thinking, well, that seems weird, but it actually worked. And so those medications are effective also. And not only that, they've been found to reduce the risk in patients with heart failure patients and cardiac risk. And they've been shown to preserve kidney function in people that are getting diabetic kidney disease. So that group of meds is also gaining in popularity quite a bit.
All right, here's a basic question. Two people, one who's sort of prone to maybe like genetically or something to type 2 diabetes, and one who maybe isn't. They both eat tons of sugar. Maybe they're both drinking like Coca-Cola or eating candy or whatever. Are they both going to become diabetic? You know how like they always talk about, oh, if you eat too much sugar, you're going to be diabetic.
Right.
Like, is eating sugar the cause of
No.
diabetes?
No, eating sugar is not the cause of diabetes, but the tolerance for certain foods, will change. If you have that genetic predisposition to diabetes, and then you are already having trouble handling glucose in your bloodstream and you have high glucose and you're eating a lot of sugar and your body's not taking that up to use it as a fuel, of course, that is going to aggravate the situation and promote more, elevations of glucose in that person. But somebody who has no problem, their body can kind of meet the challenge and pump out more insulin and dispose of the glucose by having the cells, the tissues, pull that in because there's not that resistance there. There's not the inability of the tissues to kind of take up that glucose. So so much of it depends on genetics, honestly.
Right.
So, Dr. Cooper, before we wrap things up, one final question. So we know that about 38%, almost 4 in 10 Americans are pre-diabetic. So there's some sort of impairment in the insulin system. Can you cure type 2 diabetes? I mean, can you make it go away forever?
Well, you can't. I mean, when something is in the pre-diabetes state, it is definitely reversible in that state in most cases, almost all. It's rare that if you were to detect it early and intervene early, it would be very rare for that person to develop diabetes. Once you're in full-blown diabetes, then it's much more difficult to actually reverse that disease, although it can happen. And good signs of being able to reverse it are preserved pancreas function, like where your pancreas isn't burnt out yet. So there's some testing that can be done with insulin levels, and there's another marker called C-peptide. There's testing that can be done to see that. But especially in people that have a high body weight, there's more chance of reversing the diabetes condition. But you have to remember that people with normal weight can have diabetes also. And in those people, they're known to be more difficult to treat. They're known to be more resistant to treatment. So people with normal weight that have either diabetes, metabolic syndrome, prediabetes, their body is more resistant to change. And Mark, you actually kind of fall into that. Even though you had a high weight when you came in compared to where it is now, you still would not have been considered to be like really that high of weight person. And men in that range, their system is more resistant to change, even with medication and lifestyle things. But if the weight is high in the higher obesity ranges and you have preserved pancreatic function, then there's really good chance that as you are addressing those root issues, you're reversing a lot of the metabolic drivers of the diabetes, and you'll see regression back down to prediabetes and sometimes even normal levels of glucose, and ability to taper medications. But it's not that common, and you don't want to rely on that being the case. I think diabetes is thought to be more of a lifelong condition.
Wow.
Right.
Well, this has been such a fantastic discussion, Dr. Cooper, and I think it's so important when we consider that half of Americans are either diabetic or pre-diabetic, and a lot of them don't know it.
Yes.
And you can have these catastrophic health outcomes, limbs amputated, blindness, all that stuff that can happen. This is really a topic that you need to be educated, especially if there's a family history. You know, I came to you pre-diabetic 10 years ago. My grandfather on my dad's side had diabetes, so there was a genetic component there. So this has just been fantastic. Anything before we wrap it up from either of you too?
I could say that my diabetic numbers, my A1C was much higher than it is now. I think I don't remember exactly what it was when I started, but because I was probably went up and down and then I was in a crisis situation. But right now, my last test, it was a 5.1. So, I mean, I'm doing really well. I am on medication though. So it's all under control. But I think you can make reversals with all different types of medications and different things that are available to us now.
Yeah. Dr. Cooper?
Well, I think it is so important to, number one, get screened. The American Diabetes Association is kind of slanted towards if you have high weight, screening is supposed to be done every 3 years at any age as an adult now. So they've modified their guidelines. But if you don't have high weight, they don't recommend screening till age 35 or over. But I still feel like, people should just do the screening as part of a normal, especially if you have genetic, predisposition. And to keep in mind, the screening is fasting blood sugar. If your fasting glucose level is 100 to 125, that is considered pre-diabetes. And if it's 126 or higher, that's diabetes. If your HbA1c is the average blood sugar over like a 3-month period, and you can test with just one single test, can tell you that, one single blood draw, that number should be below 5.7. That would be considered normal, up to 5.6. But 5.7 to 6.4 is prediabetes. And then 6.5 and up, diabetes. So the guidelines say, if, say, you have a normal fasting and an abnormal average, they recommend repeating the one that's abnormal once. And if it's still abnormal twice, then you meet the diagnostic criteria. So that's good to keep in mind is to do the testing. And then when you're trying to figure out, well, what could I do to like help prevent this if I have the genetics? I think that following a nutritious diet, it is important. It's not that nutrition is not important at all. It is. But having a diet that meets all the food groups, so you have all those food groups available, and you include complex carbohydrates, which are like whole grains, beans, legumes. Complex carbohydrates that are a little bit higher in fiber have been shown to be beneficial in diabetes prevention. And lots of fruits and vegetables, fish is fine, all kinds of like fats that we like to consume that are coming from plant sources. I mean, that's still kind of the dietary guidelines really for helping prevent diabetes. And if you are affected by diabetes, just try to avoid those chemical food additives as much as possible. And then being active is helpful. When you're active, when you do physical activity, it opens an extra door that the muscles use to be able to grab that glucose to use it as energy. So that it doesn't matter if you have a problem where your muscles aren't responding to the insulin. If you exercise, you can open that extra accessory door and clear out some of the glucose and get it into the muscles. So, of course, if we exercise, we want to fuel adequately. So again, no, we don't want to be doing any kind of deprivation diets. And the last thing to think about is sleep affects it, sleep and stress. So that definitely increases the risk of insulin resistance, prediabetes, if you have sleep disruption, sleep apnea, really high stress. So there's still things you can do aside from just taking a medicine, but the medication, it really, more and more that we're learning, the medication's recommended to be introduced earlier and earlier and earlier, and not waiting and just staying on a lifestyle program and rechecking your glucose in 3 years.
Well, diabetes, very complex topic, but Dr. Cooper, you've really shed a lot of light today on this disease and how complicated it can be. So thank you so much, Dr. Emily Cooper, Andrea Taylor, for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper, a Work P2P production. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.